The format that I would suggest from today onwards is that we will have case presentations. I have briefly uh, made uh, a few changes to the presentation that Anika had prepared. And I think that this format we should continue with. We will follow that format. But I, at the same time, invite suggestions from all those who are joining us on that and those who are present here in this meeting about the changes, if there are any that they want in the format. So, number one, there will be a brief case presentation along with the management that has been carried out or that is suggested. It's a complete case presentation. And then uh, I would suggest that in the meetings next to the one in which the case is presented, all those who have participated in that or who have joined us on the net, they should critically appraise that case. They should go and look up the subject in the book or some reliable sources, and then come back with the critique whether the treatment carried out was or the management, overall management of the patient was appropriate or what was wrong, what was right, and what would have been done to improve the outcome. And now, in this particular case, I will at the end show you a few more slides about the relevance of the case, and I also will let you know where to look it up. Just one complete chapter, kind of chapter, where you will look at the material, which is uh, as latest as available, and then in the next meeting on next Wednesday, it will be 24th, yes. Probably yes, 24th. I would want that in light of what you pick from that chapter, then you will present a critique and we'll listen to that for about 15 minutes. Because otherwise, I will let you know what the deficiencies or the rationale for whatever was done in this case. तो ये आप जरा चाहिए इसमें ये मैंने जैसे पहला केस प्रेजेंटेशन हो गया ये 3 अप्रैल को हुआ था हमने उसको उस दिन नहीं हुआ था लेकिन हमने इसको थोड़ा सा इसकी नोक पलट दुरुस्त करने की कोशिश की नेक्स्ट स्लाइड पे आप जाओ तो नेक्स्ट पे हमने हिस्ट्री के लिए ये किया कि हिस्ट्री में ये कुछ चीजें होनी चाहिए आजकल पहले we used to name the patient but these days we don't and even Mrs., Miss, etc. That is, but in our country here for this examination and in Pakistan, we still would stick with Miss, Mrs., etc. and wife of or daughter of along with that. And in case that we come across an issue with the specific genders, then we'll accordingly use that phraseology. So this is the suggested format. You may suggest some addition to that, some deletion, and the critique about that as well. चलें क्योंकि आपने ये पॉइंट्स लिखने हैं जो डिटेल है जो वो आपने खुद से बोली अगर उसके अलावा आपको बोलना चाहें जैसे आप पॉइंट्स हैं इसका मतलब है यहाँ पे सिर्फ पॉइंट्स दें बाकी डिटेल आप बोलना चाहो तो आप बोलो तो इस तरह से हम प्रैक्टिस करें आई डोंट एक्सपेक्ट यू टू बी परफेक्ट even if I were presenting this I wouldn't ठीक
My name is Dr. Anika Asif. Today I'm going to present a case that was related with irregular menstrual bleeding. My patient, Miss MT, age 66 year of age, wife of Mr. MT, late resident of Lahore. She was married to
दोनों ही MT थे पेशेंट का नाम था मुख्तार तबस्सुम वैसे मैं बता और हस्बैंड का नाम था मोहम्मद ताहिर
She was married since 1981 and she was housewife by profession. She has 2 kids and 1 miscarriage. Both kids were delivered by normal delivery.
She was for normal deliveries. You see, now they are grown up, they have long beards. So I wouldn't call them kids. So because they were last, she had menopause 26 years. So the terminology here would be that she gave birth to 2 sons or 2. So kid is out.
Yes.
Right? So it will be son, daughter, etc. And when was the last birth? That should be added to this. Because that's part of the history presentation, the last birth. Although that is not relevant in this. If I don't put that in, that's quite fine. If it were an obstetrical history, or if it were a woman who was in her reproductive years, then that would be relevant. The last child born. In this case, it isn't, because it doesn't relate to some menstrual disorder of the reproductive life. And all right,
She is menopausal since 26 year of
she had menopause 26
years
years ago.
ago.
Now, here again, वापस जाओ जरा. Menopause for 26 years. You should know the use of for and since. Since will be from a specific date. Menopause since 1996, or menopause for 26 years, right?
Yes.
So that kind of thing.
She presented with complaint of pervaginal spotting for 2 days. She had an episode.
इसलिए आपने शुरू में कहा irregular bleeding.
Yes, sir.
Irregular bleeding नहीं थी. She had only spotting for 2 days.
Yes, sir. She had an episode of pervaginal spotting. She went to physician and she was advised to have an ultrasound. Previously, she had no history of spotting for 26 years, no pain, no discharge, nothing. Ultrasound show multiple echogenic foci along with posterior wall of uterus.
Along
The gynecological history suggests that her menarche age was 14 years of age. Menstrual history, she is menopausal for 26 years. Previously, cycle was regular with average flow and no dysmenorrhea. No contraceptive method was used. No cervical smear were taken. Ops history, she's para 2+1
वो किधर है दूसरी साइडा
and both SVDs. Next, medical and surgical history, she is diabetic.
यहाँ पे ये मैं खास तौर पे बताना चाहूँगा कि in gynecological and obstetrical history, please do away with the caption of past history. Because so far as obstetrical history is concerned, obstetrical career is given in that, and gynecological history is separate. So what we generally in medical or surgical history we refer to as past history, in obstetrics and gynecology that will become medical surgery. So we are doing away with the caption of past history.
Sir, medical history suggests she is diabetic for 15 years on medication with average glycemic control. She had no history of surgery. Family history, no history of diabetes, hypertension, or any kind of cancer. No known allergies or habituations. On journal examination, her height is 5 feet 2 inches. Pulse was 88 per minute, and blood pressure was 150 over 70 millimeter of mercury. Respiratory was 20 per minute. On examination, no pallor, no jaundice or cyanosis.
Examination का हिस्सा जब आप respiratory rate बता रहे हैं वो भी exam. अगर आप वो को वो पहले बता दिया वो तो examine कर रहे हो. आपने height भी examine किया, आपने weight भी examine किया. That's part. और उसको continue उसी तरह से करो.
ठीक है.
ये general physical examination का हिस्सा है. क्योंकि जब आप general physical examination करते हो, you look at those parameters and then you look from head to toe. और उसमें वो सारा आ जाता है. इसमें मिसाल के तौर पर मेरा ख्याल है एडिमा मिसिंग हो जाएगा, एडिमा नहीं होगा वहाँ. वो अगर पॉजिटिव हो तो फिर, अगर नेगेटिव है तो कहने की जरूरत नहीं है. इतना जो है जनरली इट शुड बी एनफ.
Thyroid was not enlarged, accessible, lymph nodes not palpable. Thyroid was not enlarged, accessible, lymph nodes.
इसको काफी सारे लोग accessible कहते हैं. It is not accessible. The pronunciation is accessible. C is K. Accessible, lymph nodes not palpable.
Both breast symmetrical and no mass palpated. On abdominal examination, we started with inspection. Central inverted umbilicus with no visible scar marks, pulsation or discoloration of skin. Palpation, abdomen was soft, non-tender, no mass palpated. Then vaginal examination, first speculum examination shows cervix was normal looking, brownish blood on cervix was seen.
Now you can make a reference to the if there was no brownish blood, this discharge,
Discharge.
that there was no abnormal discharge or normal vaginal secretion, normal discharge. That's what you could say. Or since she has been menopausal for 26 years, you can also refer to the look of the vaginal walls. Atrophic, are there features of atrophic vaginitis or not? Or you can just say that they look normal, atrophic normal, right?
Okay.
Biomed examination आपने
So we saw that patient post-operatively, that's why.
post-operatively देखा था, biomanual examination इसमें नहीं हुआ था, लेकिन biomanual examination होना चाहिए, और अगर वो होगा तो फिर ये वाला जो है इस examination के 3 हिस्से बन जाएंगे. जनरल फिजिकल एग्जामिनेशन होगा, एब्डोमिनल को इसमें जगह नहीं है तो वजाइनल एग्जामिनेशन का हिस्सा होगा, उसमें स्पेकुलम एग्जामिनेशन होगा, और इसको पर स्पेकुलम पर वजाइनम करने के बजाय वजाइनल ब्लीडिंग स्पेकुलम एग्जामिनेशन लिखने में आप टीएस लिखोगे इस तरह से. बायोमैनुअल की फाइंडिंग्स होनी चाहिए, और बायोमैनुअल की फाइंडिंग्स में आप जो है लेट्स से एज्यूमिंग क्योंकि आप स्पेसिमेन देखा है, तो व्हाट वुड यू से विद द physical, what would be the bimanual physical exam findings coming? You would say the uterus
it was
looked antiverted. It was smaller in size, atrophic, because it is atrophic. You have the photograph
Yes,
with you. Atrophic. It was freely mobile. And there was the fornices were clear. There was no abnormality palpated, no mass, etc. was palpated in the fornix. So वो जो है cervix, तो वो आपने बता दिया, देख लिया, और बाकी इस तरह से. Next.
An investigation, her CBC shows HB was 13.5, WBCs were 12.3, platelets were normal 388. As she has poor glycemic control, her BSR was 156 milligram per DL on receiving.
Deciliter बोलो.
Deciliter.
या percentage बोलो.
Percentage, yes sir. HbA1c was 6.2. And urine complete examination show protein traces. Ultrasound shows uterus was anteverted, normal size, debrinous fluid in uterine cavity, multiple echogenic foci, 16 into 9 mm and 14.
जरा ऐसा बोलोगे ताकि वो जो है वो जो चीज है वो हो जाए, सिंक इन हो इंफॉर्मेशन जो है.
Uterus anteverted, normal size, debrinous fluid in uterine cavity, multiple echogenic foci, 16 into 9 millimeter and 14 into 10 millimeter along with posterior wall of endometrial cavity. Both ovaries were atrophic.
ये यहाँ पे हुआ था.
Yes sir. यहीं पे अल्ट्रासाउंड है.
स्पेसिमेन दिखाने से पहले अब ट्रीटमेंट बताओ ना वापस. यहाँ पे हमने ट्रीटमेंट का नहीं डाला हुआ.
Yes.
हमने ट्रीटमेंट डालनी है यहाँ पे. अब आपने ये बताया कि ये फाइंडिंग्स थी अल्ट्रासाउंड की. I would want everyone to note down these findings. Anteverted normal size uterus, debrinous fluid in uterine cavity, multiple echogenic foci or 16 into 9 millimeter and 14 and 10 millimeter along the posterior wall of endometrial cavity. Ovaries were atrophic, they were smaller in size.
Yes, sir.
So, what did we do?
Sir,
she was advised
hysterectomy, total abdominal hysterectomy. She was menopausal for
total abdominal hysterectomy. बस काफी है.
Hysterectomy along with
65 साल की उम्र में अगर
yes
आप
sir,
कर रहे हो
along with bilateral पे जो
oophorectomy.
oophorectomy.
ठीक है, तो वो की गई, और वो पेशेंट जल्दी इनके she came on 25th of March.
Yes sir.
उसी दिन एडवाइस की गई, दाखिल हुई, तो 27th को she had hysterectomy. लेकिन आपने यहाँ पे ये कुछ बताना कि ये वर्कअप ये किया था. अब I would want to think about whether we were justified in going ahead with the surgery just on the basis of the ultrasound report, and did or something else should have been done. ये आवाज आई है कि बायोप्सी की गई कि नहीं की. चले हम इसकी तरफ आ जाते हैं. आप चले आगे स्पेसिमेन दिखा दो कि वो 2 दिन बाद ये हिस्टेक्टमी. This was the uterus and you can see that the ovaries are atrophic. और आगे चलें. Uterus specimen was cut open and we found that there was this hemorrhagic mass in the cavity which was protruding out. Obviously, you must appreciate that the uterus is rather retro. And when we teased the mass a little bit, it appeared to be attached with the posterior wall in the frontal area. And on further, uh, just a little bit of movement, आगे चलो तो अगली next picture, that mass just came off. And you can see that within the cavity there is that fluid which was reported as deponous fluid, which is blood. And there is that lesion arising from the posterior wall. That's a small lesion, right?
Yes, sir.
So ये हमने किया और patient को घर भेज दिया.
Yes,
ठीक.
तो आप माँ बाप मेरे सर पे हाथ नहीं रखते मैं
yes.
अब आप आ जाओ. नहीं ये नहीं है, ये तो कॉलम ये इसका नहीं है, ये नाम छोड़ दो आप. आ जाओ. अब मैंने स्क्रीन शेयर करनी है. मैंने करनी. अच्छा मैं कर लूंगा तो हो जाएगा. ठीक है. ओके ठीक है. मैं ठीक मैं आ जाता हूँ.
progress.
उसने डिसेबल किया हुआ पार्टिसिपेट. इमरान ही करेगा. मैं इमरान को जरा फोन. सर कैसे? इमरान साहब.
सर कर दिया आपको कोर्स.
ओके ठीक. थैंक यू. ये आ नहीं रहा मेरा वाला. ये मेरी राइट. ओके. Right. So we were here, seeing this one. The histopathology report of the patient came after a few days. We took peritoneal fluid also for cytology. There were no malignant cell seen in that. And here you can see total abdominal hysterectomy with bilateral salpingo-oophorectomy, tumor site endometrium, tumor size 1.5 centimeter. I have tried, here it is a little enlarged, tumor size 1.5 centimeter, endometrioid adenocarcinoma, Vigo grade 2. So there are two types of carcinomas, endometrioid and non-endometrioid. So you look at that also. Myometrial invariant tumor invades less than 50% of myometrium. We saw in that in the specimen as well. No adenomyosis, uterine cervosa involvement, not seen cervical stromal involvement, not seen other tissue organ involvement, not seen endocervical vaginal cup margin free of tumor, parametrial paracervical margin free of tumor. Lymphovascular invasion not seen because we did not carry out any lymphatic dissection. Regional lymph nodes, we did not even try to find out the sentinel node, or since we didn't do any lymphadenectomy, so they were not there. And essentially, it is small endometrioid adenocarcinoma grade 2, and tumor invaded less than 50% of the myometrium. Furthermore, this is the tumor node metastasis classification of the specimen as far as it was possible. Tumor invaded less than 50% of myometrium. Separately present fragments of infarcted polyp also reveal few viable tumor glands. Tumor glands were there: cervix, lower uterine segment, bilateral parametria, fallopian tubes, and ovaries free of tumor. Leiomyoma that was small, that was insignificant. So this is the histopathology report. Now, in light of that, I would want you to tell me, write down these questions with the answers to which I would expect from you the next time. We'll, for the present moment, forget about this differential diagnosis. But do let me know what subsequent management, what should have been done before the patient underwent surgery. What would you want included in the workup of the patient? And then what approach should have been applied? Should general gynecologists carry out this kind of procedure, or this the patient should have been referred to an oncological gynecological specialist? What further treatment? What's the problem? Again, same problem. We don't know the problem, please. Can you tell us what's the problem? Monica ji, same problem. क्या मतलब है? वो पहले था कोई साउंड का या किसी चीज का, या मेरे गले का प्रॉब्लम? So ये है. अब इसमें मैं दो थोड़ी सी चीजें दे रहा हूं आपको. Slides were stuck. Yes, it is stuck. I am not showing any slide. It's stuck at the differential diagnosis. The next slide. You see, for diagnostic purposes, this is recommended that this physical examination refers to general physical examination, pelvic examination, which was carried out. The first test to evaluate for signs of endometrial cancer, TVS, is an effective first test with a high negative predictive value when the endometrial thickness is less than 5 millimeters. Endometrium less than 5, and if it shows it, that means that there is no endometrial likelihood of endometrial cancer in a postmenopausal woman. Combination of transvaginal ultrasound and endometrial biopsy obtained by curettage that shows to have a negative predictive value of 96%. So if the endometrium is less than 5 millimeter and on curettage the endometrium does not show any cancer, that rules out cancer in with the predictive value of 96%. And biopsy can be obtained usually as an office procedure using a number of disposable instruments developed for this purpose, like PIPL. So PIPL is an office procedure which can be done and which should be done, and which will tell you whether there are cancer cells or not. This is a summary of the diagnostic approach for identifying or ruling out endometrial cancer. And in those patients where uncertainty is there, hysteroscopy may be performed to directly visualize. But there is this issue of flushing out the tumor cells through the fallopian tubes and pushing them into probably the general peritoneal cavity. So that's part of that. Because for hysteroscopy, that will need to be. Thank you. Secondly, after a histopathological diagnosis, which may be carried out obviously by, or which may have been carried out by curettage, further, one would want to see any local extent of the tumor, evidence of metastatic disease, and also rule out other perioperative risks, because in most of the cases, it will be operative treatment that the patient will be undergoing. Evaluation of metastasis is useful in patients with suspected advanced disease, where the mass is larger and the ultrasound also shows that there is uh, 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 because when a good transvaginal ultrasound would show the status of endometrial myometrial interface, and also will let you know how much the tumor may have invaded the myometrial wall, in addition to the size of the tumor itself. And also non-endometrioid histology, because non-endometrioid carcinomas are more likely to metastasize, and comparatively early they are more aggressive. And abnormal liver function tests, that would be far too advanced stage when the liver also is the seat of metastasis in those cases. And in high risk patients, CT-based imaging of chest, abdomen, pelvis, or PET-CT may help determine the surgical approach. Cystoscopy, and this is for very advanced cases. This is not for uh, 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 a routine departmental approach, but this is the approach for gynecological oncology department. Workup generally recommended is CBC, renal function test, LFTs. We didn't have renal function test. We didn't have. We didn't have LFTs. CA 125, it has an importance for the follow up and for to seeing the progress, and also CA 125 and CEA also, they help in guiding us about adjuvant therapy. Chest X-ray, it doesn't have a lot of role except to rule out metastasis. And why it is mentioned is that it is so commonly available and it's a comparatively low cost investigation. This slide we'll talk about in our next meeting. This is people staging classification. I'm sure that लेने की क्या जरूरत है, मैं वो दे दूंगा, ये सबको मिल भी जाएगा, हम तो इसको कर देंगे उस तरह से। वैसे जो है अब दूसरी चीजें मैं इस पे ज्यादा नहीं कर रहा, हम इस पे आ जाते हैं। कौन सी ये पुरानी वाली है, ये वाली क्लासिफिकेशन, यास्मीन आप बताएंगे जरा। एक मिनट ठहरो। वो 23 वाली भी है मेरे पास वैसे, मेरा ख्याल था कि कोई बहुत ज्यादा उससे मुख्तलिफ नहीं होगी, इसलिए मैंने पहले की बनाई भी थी, उसी को मैंने रखा है। चलो अब nice of you to point out, because in 23 ये आई थी, दूसरी है मेरे पास, इसको मैं update कर लूँगा. Both of you to have pointed that out. All right. अब ये है recommendations वाली बात. ये मेरे पास से चला जाता है ये फिर. इसका these are the recommendations for practice. Actually, this is the summary.
जो अंदर से देख रहा है कि पेन बहुत स्ट्रांग बता रहे होते हैं, ब्लीडिंग बहुत हो रही है.
आप फिर ग्लव्स दो बेटे, ये जरा अपनी गली में डालो.
Recommendation: definitive tissue diagnosis must be obtained pre-operatively, which means that biopsy must be done. This will result in better selection of the surgical approach and help to differentiate tumors at low and high risk of lymph node metastasis. So, the first thing is that tissue diagnosis is recommended to be taken. Number one. And secondly, imaging might be used to determine depth of myometrial invasion, cervical involvement. Imaging that can be ultrasound, that can be CT scan or MRI. Lymphadenectomy, although in clinical stage 1 endometrial cancer is required for staging purposes, only to make sure that it has no impact on overall or relapse-free surgery. In practice, lymphadenectomy should be performed for staging only in high-risk cases. And if we do not, there is little evidence to support a therapeutic benefit, but it may be used to select women with positive nodes for adjuvant therapy. But if there is no, I would take it, if there is no lymphovascular invasion shown by the histology of parametrium, then one could assume that there is no lymphovascular invasion. In stage 1 endometrial cancer with intermediate or high risk features, adjuvant therapy has no impact on survival, but significant reduces the rate of pelvic and para-aortic recurrence. High risk patients, vaginal brachytherapy effectively reduces. So, risk estimation should also be carried out of these patients. Number 4, addition of adjuvant chemotherapy. What is adjuvant chemotherapy? That you gave after the surgery. That's right. Chemotherapy to radiotherapy in patients with high risk disease improves progression free and overall survival. Adjuvant chemoradiotherapy for patients with early stage high risk should be considered for those with serous and or P53 ABN cancers, because we saw that there was quite a detailed kind of report about the classification of the tumors. Adjuvant radiotherapy alone provides similar recurrence-free survival compared to 3 cycles of adjuvant chemotherapy. Adjuvant chemoradiation or adjuvant chemotherapy alone should be considered in patients with stage, that is for higher stages. Targeted therapy in endometrial cancer is being developed. The use of adjuvant hormonal therapy has not been properly substantiated, that is, progestogens which were given for longer period of time, but they do not seem to have any advantage in rooting out the disease. But in younger patients, comparatively, those who are desirous of having a pregnancy, uh, in those patients, progestogens are used sometimes uh, in the hope that it will reverse some part of the cancer and the patient may have opportunity to have a pregnancy. But do read that up, and this is given in this particular chapter. High risk and advanced stage endometrial cancer patients should be managed where possible by a gynecological oncologist working within a multidisciplinary team. So, high risk and advanced. Patients with endometrial cancer are frequently old and frail, and this should be taken into consideration when prescribing adjuvant therapy. So, these are the recommendations. If you look at these, in number one, of those 11, I summarize that in the number one, there should be histopathologic confirmation of the diagnosis, because that will tell you the type of tumor that it is, whether it is endometrioid or non-endometrioid, and you can have some assessment about its aggressiveness and about the nature of that tumor, and in view of which you will then formulate the treatment. Number two, proper assessment of the extent of the disease by imaging, particularly like ultrasound and CT scan, and trying to figure out whether there is evidence of lymphatic spread of the disease, uh, or in those cases where one would suspect that metastasis may be there, then assessment may be carried out accordingly. And then after the surgery, uh, 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 then chemotherapy and radiotherapy, that will be carried out according to the nature of the tumor and the uh, grading and staging of the tumor. And thirdly, and those which belong to a more aggressive nature, they should be treated by the specialized departments and oncological departments, and surgery and the rest of the care should be carried out there. Early stage, stage one, and those which are endometrioid type, they can be dealt with general gynecological surgery. This is the crux of the matter within this chapter. And as Yasmin pointed out, this is PICO's Cancer Report 2021. That was the last report that they published. That report usually comes every 3 years, so it would be due this year. And within that, there is a chapter about cancer of the corpus uteri. You look at that chapter, you read that up, and all these slides are taken from that chapter. And in addition, as Yasmin suggested, the newer classification came in 2023 of cancer of corpus uteri, which is even more elaborate. The reason for these is the greater attention to cancer of the uh, uterus is because of its greater prevalence now, and greater awareness that because of women now getting there is general increase in the life expectancy. So women who are getting older, they are more likely to have this, and this also, and then in well-developed countries, the cancer of the cervix, which used to be the commonest gynecological cancer, the incidence of that because of screening has been reduced substantially. Even in countries like India, cancer of the cervix is much lower, and therefore cancer of the endometrium now is becoming more common. As a matter of fact, in developed countries, this is the commonest gynecological cancer, cancer of the endometrium. And also, the incidence over the past 3 decades has been observed to increase because of the lifestyle, because of greater incidence of obesity and inactivity, etc. Also, the contribution given by probably polycystic ovaries and the longer exposure of the uterus to estrogens. So those are the factors by which, because of which, the incidence is getting high. On the other side, in countries like Pakistan, the incidence may not be that high as it is in the developed countries, but here the diagnosis in most of the patients may be made a little late because they see because of constraints in healthcare facilities availability, and they're resorting to that. And by the time they seek medical advice, the disease may be uh, uh, rather advanced instead of that being diagnosed in early stages. So these are various factors, but I would want you to look up and look up in this chapter in detail, and then we will further discuss it in our next session. What should have been done in this particular patient, what we missed out, and what was done right, and I'll also tell you my justification for what I did. Right? Or good question. Initial slides, yes. Quickly नहीं मैं आराम से दिखाता हूँ आप. ये हिस्ट्री में ये पॉइंट्स है because there is enough space. If you would want to add more, you can add more to this on this side and on that side as well. But generally, if there is a detailed kind of obstetrical history, you can uh, uh, may make a small table of that also and present here, or you can even add another slide. Or if there are issues with where is the menstrual history is next, so you can add that here. Presenting complaints, history of presenting complaints. This patient had just one episode of postmenopausal bleeding for 2 days only, and she sought medical advice. And so, if she had menopausal bleeding, say on 22nd of March, she came to the clinic on 25th of March, and on 27th she had her hysterectomy. So just in 1 week, everything. Gynecological history, menarche at 14 years of age. I would put a space here because I haven't done already. Menstrual history, these are components of menstrual history, contraception, cervical smear. This is part of that. And if there is any surgery, gynecological history, uh, that may be included if there is a gynecological surgical history. Obstetrical history, you can have it in detail here. Medical, surgical, family, and personal history. General physical examination, abdominal examination, and I would make another box for vaginal examination actually here. Following that, investigations, and this will take probably 2 slides as well, which is one is these baseline investigations, which will be CBC, blood sugar random, blood group if it is required, and urine examination, and then imaging, and then other specialized investigations. So if had we done diagnostic DNC or had we done a PIPL, that would be part of that would be an a procedural investigation, and that would have its own place here, and we can add another slide to this. we should have added a slide about what treatment was carried out. That was, instead of showing picture, we can show here that THBS was carried out, etc. And this illustration I think is okay. I'm going to add in this case also the original ultrasound, like we have added here the histopathology. Because in this you see the immunohistochemical stainings, and P53 was referred to at somewhere. So aberrant overexpression in tumor cells of P53, because we came across this terminology somewhere. So these are this is that part of the histopathology. Differential diagnosis is not, we haven't really discussed differential diagnosis in this case, because most of these, they do not come into this. But there was another picture which was shown, and that was of this one. This is again, sometimes you carry out a hysterectomy for thickened endometrium, which turns out to be a polyp. And therefore, that makes it all the more reason that one should go do a diagnostic DNC if there is doubt about that, if it is not something which is quite obvious. And that diagnostic DNC or polypectomy, or even if you carry out hysteroscopy, that will further clinch the diagnosis, and the patient would be saved of a major operation. So there is a lot to be said about this, because almost in half of the patients it is like that. But what prompted me in this particular patient to go ahead and do hysterectomy, I'll just share with you my reason for that. And today, that was the presence of that membranous fluid within the uterine cavity. But sometimes in menopausal women, the endometrium may not be that thick, but the presence of fluid, that's quite indicative of its malignant nature. And that actually prompted me to carry out that. And in addition, of course, there was that report of those foci which were attached to the posterior wall, and those were definitive. And I place a lot of reliance on the ultrasound report of our ultrasound colleague in this hospital. So, and fortunately, it turned out to be what we suspected. It turned out to be a stage 1 disease. And the histopathology also showed that there was no evidence of, from the, although it was comparatively limited, that there was no tumor cells seen in the parametrial tissues. So that was it. Thank you. इसके लिए इन लोगों को मैं वो दे दूं, क्या बोलते हैं, चैप्टर